All right, we're gonna get started just because we got a lot we want to be able to share with you. So, we're going to talk about Pilon fractures today and try to help you understand our thought processes as we take care of these sometimes pretty challenging fractures. My name's Clay Spittler, and I have been fortunate enough to talk two of my friends into joining us this evening. Milton Little, who works at Cedar Sinai, and Mike Giddens, who works at the mothership at Harborview Medical Center. And we got a little bit of housekeeping to go through here, just for CME and legal reasons. The AO is an AO North America independent nonprofit surgical subspecialty society that is dedicated to improving the care of patients with musculoskeletal injuries. We don't promote or endorse any particular product or line of commercial vendors. The implants you see here is for demonstration teaching purposes only, and we're not endorsing these particular brands. An overview, and then we'll dive right in. I think we want to use case examples to illustrate sort of some of the critical thinking skills that are involved in taking care of the different stages of Pilon fractures and understand some of the nuance in the acute versus stage management, as well as implant selection and surgical approaches. And we want to try to teach you how to empower stage one to be not just put an X fix on, but to really set yourself up for success in stage two, and then understand how approach is influenced by fracture pattern, soft tissue injury is influenced by fracture pattern, how we can appreciate that in both the way we handle the soft tissue, the different opportunities we have in terms of timing to address the fracture, and how implant selection is dictated by a fracture pattern. And so with that, this is sort of the end of the intro. Stage, I'm going to talk real quick and then I'm going to get out of the way so that these guys who are way smarter than me can teach you what they know. But I'm going to talk about stage one and some of the things I've learned and some of the things I've done wrong. And so hopefully you can learn from my mistakes instead of making your own as you venture out into practice. We'll try to wrap up right at 9 o'clock, so we can be respectful of everyone's time. But we want this to be interactive. If you do have questions, definitely please put them in the chat, and we will make sure that they get discussed. So for the first part of the talk, I want to talk about understanding the injury x-rays and how soft tissue, the injury to the soft tissue is something that is predictable based on the fracture pattern and displacement. And we've got some cases that will sort of illustrate some of that, and understand when I choose to fix the fibula as a part of stage one, and then how you can, sort of some of the next level, thinking about how to set yourself up to make the second stage easier with the access that you have or limited additional access to fractures, so that stage two can be an easier and more effective part of the treatment. So first, I think, it's important to look at the injury x-rays and understand the fracture pattern, the direction of displacement, and understand the forces that we have to resist to both reduce the fracture and stabilize it. When you look at the displacement, it's predictable where the soft tissue injury is going to be compromised or even disrupted. Typically, that's on the tension side of the fracture. And so the understanding where to be wary, and there's a lot of talk about acute management of Pilon fractures in one stage, and I think that there are times that's probably appropriate, but I think that understanding the soft tissue injury is important when you choose which ones you're going to treat acutely. So I think the first stage, which is still for me probably 85–90% of fractures, is going to be a staged management. And stage one is, at least in part, an external fixation procedure, right? We restore length alignment rotation, and that facilitates the early recovery of the soft tissue injury. And we want to be mindful and not just put it on an X-fix and say, all right, now go hang out for 2 weeks while we let your swelling go down. But be thoughtful in the way that we apply the external fixator and be thoughtful in the way that we reduce the fracture. whether it's closed or open, so that we can be successful in the way that we treat the patient as a part of the second stage. There are certainly many errors that can happen when you're putting an external fixer on. It's easy to leave a patient short, particularly the patient who has an intact fibula. Is easy to leave that patient short in the frame, and understanding the talofibular relationships are really important in making sure that you have reduced the fracture to an adequate length. Um, you should never leave the operating room without the talus centered under the plafond on both the AP and the lateral view. And then after you achieve that goal, and sometimes even before that, I think that there are some things you can and should be thinking about to allow you to sort of take it to the next level and do some portion of the definitive fixation uh, in a way that is soft tissue friendly and will allow you to be more successful. Let the second stage of the procedure be done more efficiently, more effectively, and in a way that you're not digging out fracture callus that's 2 weeks old while you have been waiting for this fracture to start to the soft tissue around the fracture to be amenable to surgery. So these are just a couple of different options, and I'll show you a couple examples. Fixing the fibula, right? I think that there's a time and a place for that. You have to understand the fracture and understand that the Volkmann and Chaput fracture fragments are attached to the distal segment, assuming you do not have a syndesmotic injury, which is something that's important to look for. But where you set the distal fibula in space is going to control the position of the Chaput and the Volkmann and your ability to move those and reduce those fracture fragments. For me, if I'm going to fix it, I need to know that I can make it anatomic, or I sometimes, and I think you'll see a few cases here where I choose to use a medullary implant that allows for some rotation as long as it's restored some axial stability, provides some additional skeletal stability to allow the soft tissue to recover and not be as mobile as if you had a sort of a Weber C fibula with a relatively simple fracture pattern that's just makes the whole distal limb more unstable. And sometimes medullary fixation can allow you to provide additional skeletal stability with a minimal biologic cost and doesn't box you out from any surgical approach, really. So here's just a relatively simple fracture. And this was early in my practice, and I don't know that I think it's wrong what I chose to do here. I chose to fix the fracture. Depending on the condition of the soft tissue, if was a significant, big open wound, then I'm probably going to choose to do this with a medullary implant currently, just because it is a relatively simple fracture pattern. But I do think you have to be really honest with yourself. And if you're going to fix the fibula, you need to make sure that you're going to have it perfect, because it can make stage 2 and reducing the Chaput and Volkmann fragments pretty challenging. Here's another example where you can take a diaphyseal extension of a fracture and take this from a C-type fracture and make it a B-type fracture, right? So this is a sort of a distal third tibia with an anterior escape type pilon where the talus is subluxed anteriorly. And it looks like some of my images are, so here we made a very small push-removal approach, applied a clamp, and we're able to place 2 lag screws, and that's what the the surgical approach looks like. And here's sort of what that looks like. And then I would tell you, I think that this shaft fracture in an external fixer is, even if you control the midfoot, you've got multiple pins and multiple planes, that shaft fracture there's just going to be very mobile, and so reducing it is both easier early, and it can be done through a relatively soft tissue friendly technique, and allows you to control the talus way more easily. If you think about putting an external fixer on this, it's going to be hard to keep the talus under the plafond because it's going to move through that shaft portion of the injury. So now you're able to reduce the talus and distract the joint so that you can be ready for stage 2 when the soft tissue is amenable. Here's another sort of case where this patient was transferred a while after the injury, and you can see that this valgus displacement, that distal medial spike is pushing on the skin. It's not an open fracture, but the soft tissue is certainly compromised there, and it's been that way. And there's some blistering over there. And this fibular fracture pattern is not the simplest, but I think that we can make that perfect. And so in this case, chose to, through a prone posterolateral approach, reduce the fibula, reduce the posterior segment of this fracture, the posterior malleolus Volkmann fragment, and keep the fixation out of the remaining plafond fracture fragments. But that allows us to center the talus under the anatomic axis of the tibia through this one surgical incision. And then when the anterior soft tissue is appropriate and we're sure that the medial soft tissue is not going to die, then we go ahead and proceed with stage 2. And here's what that looks like on the post-op CT scan. So reasonable job, a little bit of metaphyseal impaction there, but the joint is really lined up pretty well. And this is going to make stage 2, I won't say easy, but easier than it would have been otherwise. And then the last thing that I'll talk about, and you'll see this again, I have changed, I know that as residents, you're taught, we don't want CT scans until after the frame is on. And I have started my practice that way, but I've sort of evolved over time where with open fractures, I actually do want a CT scan, right? And so, again, predicting the soft tissue injury is important, looking at the injury x-rays, and these open wounds, like I don't ever want to go back through that wound right there, right? If I need to see something to reduce an important part of the plafond that's on the medial side, then I never want to have to open that wound. So my best shot is the first shot. And so that now I get CT scans for all of my open pilon fractures pre-op, and then often again post-op if I feel like I need it, because I want to understand the fracture as much as possible so that I can do as much as possible to avoid having to reopen primarily medial traumatic wounds. So here's sort of an example of that. This fellow had an open fracture. You can see his shaft is through his skin there. He had a pretty large open wound, relatively simple fibular fracture pattern. And in this case, we chose to reconstruct the medial column through that open wound so that it never has to be opened again. And I think if you have adequate access and you never want to have to open that wound, then that can be a powerful way to set yourself up for success, right? So this patient, he's got this very small Volkmann fragment here, and rather than flip him prone and do sort of a stage 2 on this, or portion of a stage 2, we elected to leave that for the definitive fixation. But this provides a lot more soft tissue stability. It can be done through after the open fracture debridement, and it can set you up for a much more simple stage 2. And here's similar. This is a medial varus displacement with a lateral open wound, relatively simple fibular fracture pattern, some anterior talar escape. And through that open lateral wound, we're able to reduce the fracture, place a medullary implant without any additional soft tissue insult, and then close that lateral wound and never have to open it again. Here's just one last case I'll run through real quick. This was it's never good when you read the resident note that says, chainsaw injury to distal tibia, right? That's a setup for bad juju, right? This case, here we see the CT scan. It's a relatively simple articular injury with a massive anterior and medial open wound. And so for me, I know that the best shot I've got at the front of his plafond is the very first day. And so we chose and had access through the open wound to reduce that portion of the fracture and fix these 2 large articular fragments here while leaving the Volkmann fragment unfixed, so that I could then come back and do primarily a posterior distal tibial plating. He had fibular bone loss there, but we plan to treat this with a large posterior Pilon plate. And it worked out pretty well for him. So I'll leave you with this and we'll move on. I think when I want to choose to fix part of the fracture through the open wound, I have to understand the fracture because you don't want to do something that you have to come back and undo, right? That defeats the whole purpose. If the portion of the fracture that's really important for the reconstruction is only going to be accessible through that open wound, then that's when I think it's probably the most important to do that. I think you have to have done a complete and thorough debridement, and the soft tissue has to look like it. It can't be something where I'm going to fix this and then I know it looks like it's going to die. It has to be a healthy soft tissue envelope that is healthy enough to close and me believe that it's going to stay closed and not break down. And then I want to use low profile implants because it is under that open wound. And if you're unsure of any of those things, then I would encourage you to wait because it's way harder to backtrack than it is to just wait. But with that, I'm going to let Dr. Milton Little take over, and I will get out of the way.
All right. I think that one of the things that you're going to notice here is that there's a lot of overlap. And I think part of the reason for that is because we all kind of think about this similarly. When we think about pilons aren't situations where you're going to be hitting home runs immediately, right? All the studies have shown that being patient, being thoughtful, being thorough is critical, right? So, there's nothing wrong with hitting singles and advancing the bases, day after day. And so really, I'm going to jump on kind of some of the same topics that Clay discussed to kind of reiterate that. So, I think it's important to recognize the importance of the soft tissue envelope. As Clay mentioned, understanding that the fibula can be your friend or your enemy if done wrong. And lastly, understand situations when that pre-exfix CT may be beneficial. Because like Clay, I also came to the realization that that information can be very critical in my early decision making. All right, so when I get this call from the residents, I think these are the three questions that come to mind for me, right? So, you're going to know that you're going to get this injury. You may get something like this, i.e. bilaterals that show up. And so in the end, my questions are as follows, right? So tell me about the soft tissues, right? Number two, tell me about the fibula. What do you know about it? What's the injury? What does it look like? And then number three, does the patient have a CT yet? And really the thought process is like we talked about, understanding where I can cause problems, where I can kind of make mistakes, and where I can avoid things that could lead to complications for the patient in the future. So simple answer is it open or is it closed, right? And once you ask them if it's open, how open is it? And where are those openings, right? How severe is the soft tissue injury? And is this something that you anticipate is going to need soft tissue coverage in the future? Is this something that may be a closable injury, right? And a lot of that we don't know until we get the patient to the operating room. But really, it's being thoughtful in terms of your evaluation and your understanding from the residents and from the first responders for the injury. And then what about other things? Are there blisters? Are there soft tissue complications that are going to avoid any type of intervention in that first stage? How bad are the blisters? Are they hemorrhagic? Are they serous? What is going to be something that is going to delay this person undergoing definitive intervention and is also going to help us understand when this injury happened, when the patient presented, and how that may impact our next steps in management. And then what about skin at risk, right? So it's obvious that this patient has an open injury, but the other thing that stands out when you look at this injury is kind of the soft tissue envelope and that red area of skin pressure right on that anterior aspect of the foot, right on the dorsal aspect of the foot. So this is something that's going to need to be reduced quickly, even though it's an open injury, because that soft tissue injury can be something that causes real problems later when we're trying to make our decisions for definitive management. right? So really thinking about it, being thoughtful, looking for all of these things, and then understanding if a patient has previous incisions, how those incisions may affect you, what hardware may previously have been placed, and how that hardware has impacted your or will impact your decision making in the future. What about the fibula? As Clay mentioned, is it comminuted? Is it simple? Is this something that is where you can get it anatomic on the first date? Number two, is this a patient that you're going to be managing long term? Right. So you may love what the fibula looks like. You may have an idea of how you're going to treat this definitively. But is this something where you may not be able to do the definitive management for this patient for some reason, some form or not? Right. You need to think about that because your interventions can hamstring or impact the person who's going to be managing them in the future, right? So if, especially in situations, when I think about this in terms of our residents going into um, into the real world, if you're thinking about fixing the fibula and you're not thinking about doing the definitive management, then you may want to remove that thought from your head if you don't know exactly how you're going to go about definitively fixing it or how whoever is in the future may do that. Right. And is this a comminuted injury? Is this something that you're going to have difficulty getting the length, alignment, and a rotation appropriate? Or is it something where you may be able to get an anatomic reduction that's really going to help you or your partner in the future? Is it length stable? Right? When we talk about not utilizing non-surface implants, so intramedullary type implants, right? Is this something where there's not a big shear injury or some comminution that if you're using an intramedullary implant, it's going to allow for shortening that could impact your definitive fixation, right? So understand if this is a transverse injury or a length stable injury, how you can go about managing it and how you may go about addressing it. And then lastly, am I gonna am I going to burn bridges? Right. So if you don't have a pre-op CT or a true understanding of this injury and the way in which you may move forward with definitive management, choosing to place a surface implant or make an incision for either a kind of lateral approach or even if it's posteriorly a more posterior approach or a posterior lateral incision, these things may impact your ability to move forward in the future. So really thinking about that can be important. And so, like we talked about, does the patient have a CT scan yet? And for me, I want to know if this is an open injury, because if it's an open injury, I 100% want a CT scan so that I can assess what's going on and how that open injury may allow me to move forward, hit a single, or make the most of that first stage of my intervention, right? So I really do want that CT scan. Is the articular surface simple, or is there a simple metaphyseal or metadiaphyseal component? I want that CT scan, even if it's a closed injury. Once again, for that kind of technique as Clay displayed, converting a C-type injury to a B-type injury. This is something that can be very powerful and very important in moving forward with management. And once again, thinking about that CT, right? Thinking about that fibula. Is the fibula something that I can address early? And is it something that is going to help me with my next steps? And how does that CT help me in terms of my planning with that open injury with my fibula injury? And so here you can see a patient where we had an open medial wound. You can see that they had a CT scan that was not perfect, but did have some characteristics that allowed us to think of it as a length stable type injury. And then you can see where we intervened on that first stage, taking care of that medial wound and avoiding the fact that we were that medial fracture and avoiding the possibility or the need for going back to that medial wound, as well as avoiding situations where I may have to move backwards and making it a little bit more simple for that next stage in management. And this is when you think about that CT and your ability to avoid burning bridges. And so you want to think about your approaches, whether you're going to be managing this through an anterior lateral approach, i.e. B, an anterior medial approach, i.e. Point a posterior lateral approach, or a direct lateral approach, or a posterior medial approach or a direct medial approach. Really understanding whether you can avoid burning bridges with that first stage where you're trying to help yourself moving forward. And then what are going to be your next steps in management? And so for this patient, we went back through an anterior lateral approach and were able to do the final definitive management for this patient. So I will stop there and I will kind of let things go for Dr. Githens.
Okay. Well, thank you guys for having me. This is like drinking from a fire hydrant, huh? Pilon fractures. I'm always so excited to talk about them, but always have a little bit of a sense of doom as well. But we'll get into some cases. I think that really there's been so many interesting points laid ahead of us, and a big part of I think what makes this webinar really fun is getting into a little bit of a higher level discussion. So we've got some of the basics laid out. I think everybody is fairly experienced with the basics of Pilon. And so now we can talk about some application of the higher level concepts in some cases. I'll get through a few, and then if we have time, we'll get through some of Milton's. But basically drive home some key concepts and then generate some discussion. One thing that I think I'm seeing a lack of is conversation in the Q&A. So please, audience, participate if there are things that are confusing to you, things don't make sense. If you have questions that pop up, just put them in there. Clay and Milton are looking at this, and I am going to go ahead and get some cases rolling. So this is a 49-year-old male, pedestrian versus auto with an anterior scaped Pilon. So I'm going to engage both Milton and Clay on this. But Clay, I'll ask you first. So when you look at these, so I'm going to present some atypical Pilons rather than going through sort of the bread and butter stuff. When you look at this, what are just a few initial thoughts that you have? What is your gut reaction? Anything that just sort of, comes to the tip of your tongue?
Yeah, I mean, these are tough to treat, right? There's a lot of anterior rim comminution in addition to the articular impaction that makes holding on to these anterior fracture fragments really tough. I think, looking at that foot without it being a perfect foot x-ray, I bet that this patient has somewhat of a cavus foot and a tight heel cord. And that's a big part of why this talus came out the front. Those are just sort of my some of my initial. The fibula is intact. Those are sort of the first things that come to mind.
Milton, any early thoughts for you? The gut reactions?
No, I think that the gut reaction is similar to what Clay said. I think that the gut reaction is oftentimes sadness and an idea for these patients that, I think all Pilons are life-changing. These Pilons can be particularly life-changing. And I think these are Pilons, as you're going to discuss, where it's really a little bit of a different question in terms of, when someone asks me, what's going to be my post-operative plan after my definitive surgery, right? So I think that that's something that when I'm thinking about this, I'm really thinking about that discussion with patients.
Yeah, that's awesome. So to me, when I look at this, my stomach turns more when I see a Pilon like this as compared to one where you have the typical 3 fragments plus central impaction and maybe metaphyseal and even diaphyseal comminution, because all of that energy went through a very small focus. And as both you and Clay mentioned, when these things try to fail, they try to fail in the same direction. And when you have good bone stock and you can recreate that and you can resist the deformity, we have a better chance of success. But when you look at something like this, it's a very small portion of the plafond that has seen all of the energy. So to me, these make me more sick to my stomach than some of the other Pilons for a couple of reasons that we're going to discuss. The other unique thing about this one in particular is if you look at all 3 of those images combined, the talus is completely in front of the fibula. and the fibula is intact. And so no matter what view you're looking at, I think it's important to recognize that it may be really hard to get the talus off of the fibula. So paying attention to these injuries, even when you're thinking about, okay, this is staged, I'm going to simply do an external fixator, that this may be locked in the front of the ankle, and it may present a little bit more of a challenge than anyone is expecting. So my stomach is turned. I'm taking the patient to the operating room. We're going to do a standard delta frame for external fixation. And we did, in this case, have to do a little bit of maneuvering in order to get the talus off of the plafond. But I think this is, especially if you kind of hide mine and everybody else's faces to the right of your screen, you can see that there's most of the plafond is intact with a little bit of the anterior rim injured. And that may be deceivingly simple to to folks who don't have experience with this injury. But to me, when this is pulverized here and the talus is out the front, I really worry about this. So this is always, in my hands, going to get stage management. I don't think that there's a great role for early ORIF for this particular type of injury. And here's the CT scan, which just simply corroborates what we know, which is the anterior quarter of the plafond is completely dusted. And that makes that creates a pretty significant problem in that we talk about intrinsic stability when we reduce and then fix a fracture, right? Like if you can recreate a stable skeleton and use the plates to augment the bone, whether that's the subchondral bone and the supporting metaphyseal bone, you're going to have a much better chance of maintaining that reduction as compared to something where you're rebuilding a lot of small fragments and resisting a lot of force. And that's the case here, right? This anterior plafond, you can get a sense, is really pretty powdered. And we're going to have to try to maintain the station of the talus under the plafond by reconstructing this powdered bone. So the question is,
hey, Mike,
yeah,
I guess just going back to that CT scan.
Yeah.
Just thought process for me. The other thing that I'm really looking for this CT scan is any marginal impaction on that posterior segment, right? So I think sometimes you can sometimes rush looking through it and not recognizing that marginal impaction, just making sure you're being really thoughtful and looking at all of those cuts to make sure you're not missing something from that standpoint.
Yeah, that's a great point, and thank you for interrupting me. Please continue to do it because I'll miss things. But yeah, you think about this just like a posterior wall. Any partial articular injury is going to have some degree of marginal impaction or a big skid zone, and in these cases, that can be really, really challenging to deal with. So absolutely need to recognize it, plan for it, and have a strategy to bring it down. So when you look at, there's been a few studies that have looked at this, and I don't want to get into the weeds with it, but I do think that this study particularly drives home the point that if you don't contain the talus in these anterior escape injuries, it's a losing game. And so bottom line is, when the talus comes out in the front, you have a skid zone on the plafond. They're going to have a higher rate of arthritis, period. So that's important prognostically. And then if the talus does go out the front after you fix it to any degree, whether that's a little bit of anterior subluxation versus complete subluxation, the risk of developing post-traumatic arthrosis and true treatment failure is significantly high. So what that does is it puts the onus on us as surgeons to say, okay, this is a different beast, right? These anterior escape pilons are different beasts. So how do we think more specifically about addressing the potential pitfalls of this injury in order to sort of optimize patient outcomes in regards to preventing anterior escape and plafond? So here's my thoughts, and I'll leave this to Clay and to you, Milton, in regards to an injury like this. Are there things that you're doing that are different than your standard pilon fractures for these anterior escapes, whether that's intraoperatively or postoperatively?
So I'll go first. I think for these particular fractures, most of the time, if I have a metaphyseal void, I'm going to use just plain allograft bone to fill that void. I think a lot of times I'm more more likely to use something that is more structural, so a calcium phosphate type bone graft substitute in the void immediately above the subchondral surface that is inevitably here. I think it's also and I think you probably did this. I think it's really critically important that every single articular fragment has an implant that secures it, because these are like freaking chiclets, right? I mean, and you cannot just say, it's kind of all under the plate. Like, I think that's going to be okay.
Yeah, I agree with what Clay said. I agree with the fact that you are getting every single fragment. And then I think that the unloading and the protection for this patient is really critical. And so, if there is any question about the amount of um, metaphyseal support or support for other articular fragments, then the maintenance of an X-fix after the fact is really critical. One of the things that was mentioned in the Q&A was the idea of using a ring fixator for these. I have not used them, but I think, one of the possibilities for doing that would be allowing a patient to then weight bear to get them up and get them moving, rather than a static, a static X fix that they cannot weight bear on. So it does seem like a reasonable option.
Yeah, I completely agree with that. I think that fragment specific fixation and anatomic plafond reduction, fragment specific fixation is very important for this injury. But then, as you just said, offloading it in whatever way works, whether that's a ring fixator and letting them walk on it versus a static X fix like this and keeping them off of it. I think the most important part here, at least in my mind, and I think collectively ours, is protecting that fixation, because again, that's a small area that's going to see a lot of load post-operatively. So I think protecting it in one of those two ways is important. I think there is an argument and a role for a gastrocnemius recession. I think this came up. Clay mentioned this when he looked at this patient's foot. But if you're looking at if we're looking to tip the balance in this patient's favor, there's some small things that we can do. I think a gastroc recession is something to consider, certainly, in regards to, again, offloading this. And then if you think about sort of the vascularity of the anterior plafond, there are patients who will develop in the postoperative period, as they're revascularizing these fractured fragments, some degree of, well, I mean, every patient is going to have softening of that bone there. Some patients are going to develop a little bit of avascular necrosis of those anterior plafond fragments. And so for me, adding a custom dynamic offloading AFO once they're weight bearing, at least anecdotally, seems to be another small way to tip the scale in these patients' favor in regards to keeping the talus under the plafond. So these are kind of some of the things that I'll think about in regards to basically backing up all of the hard work that we've done on the front end, so that the talus isn't coming out the front. So this patient I actually treated with an anterolateral approach. One thing that I wanted to bring up, I guess, and we'll talk about it a little bit more in the next case, is how do you choose your approach? Of course, it's the skeletal injury plus the soft tissue injury. In this case, it's a directly sort of anteriorly based injury pattern. So one can choose an anterolateral versus a direct anterior versus an anteromedial approach. And I think the most important thing in choosing anterior versus anterolateral is preventing bowstringing of the tendons. Anteromedial is a little bit more extensile, allows you more access to the fracture fragments, but it has a little bit more increased risk of marginal necrosis and potential wound breakdown and infection. So I think one just has to weigh all of those things when making that decision. In this case, I chose an anterolateral approach for this. An anterolateral approach classically is defined by working lateral to all of the anterior compartment structures, right? But the truth of the matter is you can work in whatever interval you need and place that incision where you need to. Most importantly, though, is respecting that extensor retinaculum, making sure that you can close that so that you avoid bowstringing. So for me, I actually, and I know my partners and many people around the country will use a Z-plasty of the extensor retinaculum when you're dealing with a patient who may be under tourniquet, may have a long operation, and may swell a lot, where it makes a straight line incision through the extensor retinaculum really hard to close. So I think if you haven't seen a Z-plasty for the extensor retinaculum, get into a cadaver lab and experiment with it, or ask some of your staff if they have any experience with it. And you can see that in this patient, we actually came way medial through an anterolateral approach. And that's just working through the different intervals offered through that skin incision. So that's my comment here in regards to anterior access through an anterolateral approach. And here's follow-up. This actually was a patient pretty early in my career. He's had a couple of chylectomies, but his talus has stayed underneath the plafon, and despite having some anterior arthritis, has maintained a congruent tibio-talar joint. So before I move on to the next one, any comments from either of our faculty member, or do we have anything in the chat that we should address?
I think a
Yeah.
couple things. Oh, go ahead, Clay.
Go ahead. No, go for it.
I just answered one of the questions in the chat. You know, he used a cuneiform pin for dorsiflexion for the forefoot. Gets you a little bit more control. It's a little bit more robust, especially in a patient who, compared to kind of a metatarsal pin or some kind of other forefoot pin, which can loosen early. So that's just, that in terms of that question. And then for you, Clay, anything?
Yeah, I was just going to add, I think that midfoot control is important. I think in these patients, particularly the ones who have sort of a fixed equinus, that gastroc, so if you're really forcing the foot into, a neutral dorsiflexion, you're putting all of the pressure on your fixation that you've just spent the last 2 to 3 hours reducing and fixing. So doing the gastroc recession allows the talus to be distracted slightly more, so that the anterior talar neck is not just absolutely crushing your fixation that is often tenuous at best, and really distracting the ankle joint to then allow you to get the foot plantigrade and in neutral position in these cases is really pretty helpful.
Yeah, and before I move on to the next case, I did want to say one thing that I kind of forgot about here. But Milton, I love when you said Pilon fracture treatment, it may just be like advancing the bases, right? Like, let's get a single, let's get a double, let's not go for a home run here. And for me, and when I started taking care of some of these patients, the idea that I was going to do something like leave an X-fix on for 8 weeks or come back and slide a medial plate up was adding something that made me feel bad to tell the patient, like, I am creating more of a burden out of this by potentially adding something unexpected, which I think is the wrong mentality to have. I think the mentality to have in that conversation to have with the patient is saying, hey, what you have is a little bit unique. And what myself and collective experience and my partners and my colleagues have learned over the years is this is going to take a little bit extra. And so you may have to have an X-fix on. And I'm sorry, I don't like it. You don't like it. But I genuinely think that's the best thing for this injury. And so I do think having that mentality of like a little bit more in some of these cases, it may not feel great for you as a surgeon, but it may be the best thing. So listen to that and just be a little bit more okay with saying, hey, look, like if frame is going to be a bummer for the patient, but if I genuinely think that it's going to help improve their outcome over time, talk to them about it and do it. All right, so next case, very different. This is a 35-year-old motorcycle injury. Let's consider it an isolated and closed injury for purposes of this talk. So, I mean, polar opposite from the last injury. So when you look at this injury, there's a lot of questions that we can go through. Some of them have been addressed directly. Some of them haven't really. In something like this, Clay, in your mind, this is a tibial shaft fracture plus a pilon. It's like, pilon, it's not a horrible pilon. It's not the easiest pilon. Is there any role for definitive acute fixation in your practice for something like this? And if so, tell me why, and if not, why not?
Yeah, I mean, I think a couple things. So I would say that that is dependent entirely on the soft tissue envelope. And this is a pretty high energy injury, and high, comminuted fracture pattern. The joint surface looks relatively simple without a CT scan. Certainly, before I would dive into acute fixation, then I would want to have that information. But I think there's sort of two components to this injury in my mind. There's a shaft fracture that most of the time is best treated with the nail. And then there's an articular injury with the segmental fibula fracture. And so there's a lot going on, but I think that if the joint was very simple and the soft tissue was just pristine, then yeah, I'd go for it.
Yeah, I mean, I think those are all the most important points, right? Is like, what are the soft tissues like? What's the energy that's gone through the leg, and then can I reasonably do this in a contained amount of time without extensile approaches? Where
Mhm.
I've gotten into trouble with acute fixation for pilon fractures is one, I under anticipated how hard it was going to be, thus under anticipating the length, thus in
Yeah,
under anticipating the extensile nature of my incisions. And when you
yeah,
do that, I think you set yourself up for a really big problem. So I think there's been a push towards, or a pendulum swing towards, early definitive management for pilon fractures. And I would push back against that with the very rare patterns where you say, I can do this do this quickly, do it well, and do it through relatively small incisions. And when I look at this for myself, I say I'm not confident that I can do that, so I'm not going to do that. So this is going to get staged management for me for sure. So Milton, you talked about the value of fixing the fibula and sometimes leave it, sometimes fix it. When you look at this segmental varus failure, low fibula, and then sort of a Weber C type of fibula, is this a fibula that you would fix at the time of X fix, or is this something that you would potentially wait on versus not fix at all?
That's a great question. I'm in here like trying to zoom in to get to the bottom to understand what that kind of most distal fracture line is.
I don't have anything that's going to help you. Let me tell you though, it's a pretty simple, sort of a little more oblique than transverse without a significant amount of combination.
Yeah. I would think about it. I think a lot of times with the segmentals, I'm going to be a little bit more patient with it. Unless it's kind of true segmental, kind of true transverse, where, it may take a little futzing to get it done, but I can use an intramedullary device, without kind of a big, soft tissue assault. And given the kind of segmental nature of everything, I feel like those soft tissues are not going to be amenable to adding a big incision on the side of there.
but
Yeah,
I'll play devil's advocate a little bit. I think here, because of the extensive comminution up to the mid shaft, almost like this fracture needs more skeletal stability than a pure external fixator can provide. And so I agree. I think that sort of distal third shaft fracture is amenable to a medullary implant, and then I'd have to see it a little bit more closely through the CT scan. But you can sort of reduce that distal fracture and either only through a pretty small incision,
Mhm.
and either lag outside the middle of the medullary canal, mini fragment plate plus the rod. I think that's a reasonable option that I can get that done, and that provides a lot of stability to this leg that really doesn't have much.
I like it. I like the controversy, and I don't think that there's a right answer. And I'll tell you what I decided to do was external fixation for the plafond. And then, given that the proximal fibular fracture is length stable, to treat it with a medullary device, both of the fractures. And of course, despite putting as much distraction on as I could through the medial column, once I had that rod up, it resided in varus, and the distal fibular components resided in significant varus following the talus. So I ended up sort of with a hybrid construct where we did external fixation, medullary implant for the fibula, and then actually revised the distal fibula around the rod when we came back and did the tibia. When it comes to doing the tibia, I heard talk about a nail for the meta-diaphyseal component for this. We have learned in our AO basic courses that typically when we're doing that or we're deploying that strategy, we're looking for functional reduction, indirect reduction, length alignment rotation, and then a flexible implant like a medullary nail to control it and provide secondary bone healing. So is that a strategy that you would employ here? Would you closed nail this and then ORIF Pilon, or would you think about that a little bit differently?
I think I would think about it kind of a little bit in some hybrid formation of that, right? So looking at this proximal fracture, which looks relatively simple, thinking about the fact that I may be able to at least get those fractures contained with a small percutaneous incision to make sure I'm getting my reduction right, clamping that proximal fragment, making sure I'm thinking about that same thing for that second fracture line. And if I can do that, a very small open reduction while still getting my reduction correct. So anatomic-ish.
Yeah, so I completely agree with you because if you think about there's no containment from the isthmus down, and then you have a plafond fracture to deal with. So I think that's a really, really, really hard closed nail to do and still maintain coronal-sagittal plane alignment, especially because you don't have the opportunity for blocking screws distally. You just don't have a lot of salvage options if it doesn't go well. So for me, if you create a bone tube down through the metaphyseal transition, you have given yourself a very straightforward nail and then a pretty straightforward plafond. So that's what we ended up doing. And again, the fibula that was a rod only first, and we ended up having to revise around it in order to drag the thing out of varus. But limited direct reduction for the meta-diaphyseal component of this, and then ORF of the plafond through a limited anteromedial approach distally. And that all was safe because this was a closed fracture. And the next case that we'll talk about is how soft tissue wounds will affect your ability to do the approaches that you want. Before I move on from this case, though, the patient, ended up with an acute compartment syndrome, which is fairly rare after Pilon fracture. If you look at either stage, either external fixation or ORIF, but when you have metadiaphyseal and diaphyseal extension like that, it's a fairly significant concern. So that this is another reason why I'm just completely staying away from early open reduction and internal fixation for ones that appear like this on my OR list. Any other comments before I move on, or questions that we need to look at?
How often are you using the intraosseous screws there, or the intracortical screws?
I love this strategy. They're clamp replacements for me. So if I know that I've got semi-contained butterfly fragments, especially very long semi-contained fragments, and what I mean by that is part of the medullary canal is around the nail, but it may escape after the clamps come off. I'll have a very low threshold to put a 2-4 screw as a clamp replacement so that you maintain that bony contact and help promote union. I think this can get confusing for those who take their AO basic course and say, wait, I've got a medullary implant and now I've got screws around it. Isn't this mixing and matching primary and secondary bone healing, and are we generating non-union? And the answer is no. These screws are simply clamp replacements in that they're flexible. They're 2.4 or 2.7 millimeter diameter screws, usually 2.4 intracortical screws. And there's some wiggle that's allowed in the fragments, and you will see callus formation around these fracture fragments over time. So if I am open clamping metadiaphyseal fractures, rather than leaving a plate on or letting those fragments fly, I'm very happy to put a 2-4 screw in an intracortical position to maintain it.
Very nice.
Okay, so last case on my list, and if we have time, which I guess doesn't look like we're going to go through some of Milton's, I apologize. This is a 29-year-old. He fell from a ladder. He's got a oblique medial wound, exactly where you would expect it to be based on the distal end of the proximal segment. He's treated at an outside hospital with external fixation. He's transferred to your facility 4 weeks after his external fixation, and these are his presenting images. So Milton, talk to me.
I'm really curious as to what the wound looks like, because based on the alignment, it seems even if they were able to close that wound, it is probably still under pressure and likely not particularly healthy looking.
Yeah,
So
I'll
I
tell
think,
you, it looks like shit. It's
yeah,
not good.
so I think so. The fact of the matter is, I think they've already kind of helped me make some decisions. So my first day is really restaging, doing an appropriate debridement, removing the non-viable tissue. I'm also thinking about, I'm getting a CT scan, so I know from an incision standpoint what I'm doing, but knowing that, I'm going to get my plastic surgery team involved with a plan for when I do move forward with definitive management. If this is something where I can do a fix and flap in the same setting, that's what I'm going to be thinking about.
Clay, how could this have been avoided in the get-go?
Well, I mean, I think stage one is really important, right? If you're not going to set yourself up for success, like it's a thorough, adequate debridement. I think additional. It looks like we've got a single pin in the distal segment, which you can see the pins. The standard anterior to posterior tibial pins proximal to where they're visible on the X-ray. The apex of the fracture deformity is exactly what you would predict based on the trajectory of those pins, particularly because you have no control of the midfoot or forefoot, and just really and truly kind of a subpar reduction here has led to probably continued soft tissue necrosis at that medial soft tissue envelope, which is really hard to deal with.
Yeah, so I hope everybody listening, I mean, everybody listening has heard we don't just slap X6s on, right? And this is the reason that we don't. If you just put a standard delta frame on and don't understand the displacement vectors, then you're going to end up with something like this. So if we walk this back to what Milton and Clay talked to us about earlier, you've got a medial open wound on the index operation where you do a debridement irrigation, pretty simple read with a tension failure. So it's begging for at least consideration of a mini fragment implant to help maintain the reduction on the medial side. The fibula is certainly not an easy one to fix, but if something failed in valgus, significant valgus to begin with, it's going to want to fail in that direction again. So fixing that fibula would have been another way to help resist that. And then lastly, as Clay pointed out, with the lack of a midfoot pin, you can see that the vector of the external fixer is going to put this thing into significant apex anterior. So this is, unwinding these problems 3-4 weeks later is a huge problem, a huge disservice to the patient. So just, sear these images into your mind when you think about, okay, I'm not just putting on an X-fix. What are my specific intentions? What's the deformity? How do I resist it? How can I set this patient up for success? So that patient ended up with a revision external fixer on day one when they showed up, repeat debridement irrigation. Medial wound didn't need a flap, thankfully.
Hey, Mike, one thing just, of note, I would say this, when you're putting on an X-Fix, it's not a race. You're not trying to do it as quick as possible and get the patient out. If you're the attending and you're running a second room, it's not the place where you put your two just to hang out and do nothing. Every X-Fix that goes on should be put on as if this is the definitive management for that patient. Because there may be head injuries, there may be abdominal injuries, there may be something that precludes you getting to this in 1 week, 2 weeks, 4 weeks, 6 weeks, 2 months. And if you put it on in that fashion, you can set yourself up for success later.
Absolutely agree. Couldn't agree more. So here's a skeletal injury just above the plafond. We talk about how we choose our surgical approaches. Milton mentioned all sort of the circumferential approaches available to us. This is something where I'd look at and say, okay, well, where is the articular injury? And of course, we'd have to scroll a little bit early or further down. We're always concerned with sort of the skeletal injury, the location of the impaction, our access to the impaction. But what comes into play importantly, in this case and in many cases, is what's going on with the soft tissue and how does that affect our ability to do the approaches that we actually want to do. So I tell you, as we scroll down to the patient's articular surface, this is something that's probably best treated with an anteromedial approach. But again, the patient has an oblique, really gunky looking medial wound. And then if you look more closely at where this fracture is really gapped, and especially the soft tissue windows, you can see that there is posterior tibial tendon as well as a neurovascular bundle entrapped within the posteromedial space. So what goes from a fairly simple, let's do an anteromedial approach, becomes, okay, well, we can't do that because of the soft tissue injury. I'm going to be forced to an anterolateral approach for the skeletal portion of this. But then even with my careful clamp placement, I've got a bundle and tendons in the posteromedial aspect. So I think it's very important, and every injury is going to be a little bit different and a little bit nuanced. So the point of this slide is really to say, hey, yeah, you're going to focus on the skeletal injury and you're going to look for windows that lead you to the impaction, whether that's usually anteromedial versus anterolateral in the size of the chaput, versus what the soft tissue has offered you. And the soft tissue trumps everything, because if you say, hey, I don't really care, I'm going to do the approach that I want and see what happens, that's going to end up in a below knee amputation, not infrequently. So I think it's really important to sort of put together or wed the skeletal injury with what the soft tissues have offered you and try to find the best way to do it. So in this guy's case, we ended up doing an anterolateral approach for the articular injury, which is definitely suboptimal and more challenging in regards to it, but it's something we have to accept. A limited posteromedial approach in this patient's case, which was probably about 3 centimeters in length, in order to simply visualize the tendons in the posteromedial in the bundle and extract those from the fracture line and then allow clamp application free of entrapped structures. And then the last part of this is, does this patient need dual column support? And I would argue that in most C-type fractures, especially those with any sort of significant bone loss or comminution through the metaphysis, a dual column plating strategy is very important in regards to maintaining reduction and preventing non-union with deformity. So in this case, we were able to safely slide a medial plate up underneath the patient's traumatic wound and put 4 screws in a percutaneous fashion. I would say do that very cautiously, and in patients who have an open medial wound where you say, I think that they need medial column support. Again, there's nothing wrong with going back to Milton's strategy of let's just hit, let's take this in pieces. And there have been plenty of patients where you say, I'm going to come back at 4 to 6 weeks when your medial wound has dried up, it's healing or healed, and I can slide a long medial plate up, avoid the zone of injury, put screws below, put screws above, let that sit for 6 weeks and let them start walking, as compared to somebody who you say, you have a medial wound, I'm never coming back there, I'm not touching it because of your risk of infection, wound breakdown, soft tissue complications, but a skeletal injury that really needs it. There's a compromise there, and I think delaying placement of that medial column fixation, there's definitely a role for delaying placement of that medial column fixation. In this case was borderline for me. We did it acutely, but have no problem with coming back at 6 weeks to add that plate. Any comments from either the chat or from our faculty?
One of the questions was just asking if you'd put that medial plate in during that first debridement. And, my response to that was, it really is a question of understanding how, how contaminated, how, whether it's a clean injury or not on that medial side, that's really going to determine your timing. Same for if you're doing any acute open wounds and utilizing those open wounds for early intervention. Really, an open wound that's not grossly contaminated is very different than an open wound that's caked in mud or feces or dirt or something that really is going to need multiple debridements before you can before you can consider it clean.
Yeah, I completely agree. I'd say that in our collective practice here with the 3 A's, there's very, very, very few that are not adequately debrided to the point where you can accept an early implant. I think it's those where you have progressive myonecrosis or just an extreme example of contamination. I would have loved if this patient was my own from the index. I would have loved to have that plate there with that medial wound closed on day one with the fibula fixed. Because again, that, as you guys have sort of hit on over and over again, that facilitates a much simpler second stage and really helps to promote healing on that medial side and mitigate their risk of wound breakdown and infection.
And I think the other thing that Mike, while that's a complex fibula, if you have that simple medial fracture that you can get anatomic, you can now dial in your length on the lateral side, right? And use both to do the work rather than now depending on a comminuted fibula in the setting of a bunch of medial comminution and trying to predict your length.
Totally agree. So I think we're hitting, we're 6:05 right now. Clay, you think we?
Yeah, I think we, as much as I would love to continue the conversation, I think we probably should wrap there. I'm looking at any questions in the chat here. There's a question about an osteotomy early or late to offload the anterior plafond. Like Mike mentioned, a lot of times when I've never done it acutely. I have seen it and have it be successful sort of in a delayed fashion, but never for that was it was really as a malunion reconstruction that I did that had some talar subluxation. And it was a posterior subluxation. The anterior plafond escapes, like the fragments are so small, and as Mike mentioned, you often get this AVN of some portion of them that once the talus starts to go, I don't know that I think there's any reorienting of the distal tibial metastasis that's going to prevent end-stage arthrosis of the ankle. When the talus subluxes and you lose some, even if it's 15-20% of the anterior plafond, I think that ankle is cooked. Any experience with that, guys?
None on my end. No, I think it's all sort of the preventative measures that we talked about. But I think an osteotomy, I guess in theory would be nice, but in practice would be really hard to get right in a useful manner, in my hand.
Yeah, no, I agree.
I think there's simpler solutions.
Yeah.
Let's see, Mike, if you'll turn off your screen, I got
Yep.
one more slide to show just for upcoming events. We really appreciate everyone coming and listening to what we have to say. We hope that these fellow webinars are beneficial to you, to add some additional context and additional opinions from all of the different mentors you have in your own fellowships. Our goal is to help give people tools to take really good care of patients, right? That's what we want to accomplish here. And I think that both the friendships that we make through the organization are really valuable, but also just learning from each other is really valuable because it really does affect the patients that we take care of. And I've learned a lot from these guys and others before that I think have helped me become a better doctor. And so that said, there's some upcoming webinars that I would encourage you to try to attend with some great faculty and moderators who will really further your knowledge on these topics. And this is my plug for the AO. I think that consider being a part of it once you get into practice. I think it will help you and encourage you to continue learning and continue to improve upon yourself and your surgical skills in the way that you think about these challenging problems. But with that, we'll say thanks and hope everyone has a good evening.